Okay, two quick examples on how to load the panoptix lens. The panoptix is in this little cartwheel case, and there's a ringed central area of the panoptix, and then there's a smooth peripheral edge. You never want to grab the implant by the central area. You always want to grab it by the peripheral edge, because this lens is very easily scratched by any metallic instrument. So we're grabbing the peripheral edge with the smooth blue or Kelman McPherson tying forceps. We slide it into the cartridge. The cartridge is filled with viscoelastic. Any viscoelastic will work. There's a diagram or a kind of an outline of a lens implant on the back of the injector. And you never want to grab the lens implant with the Kelman and McPherson forceps in the area where the rings are. It's okay to grab the very peripheral edge, trying to advance the lens down the cartridge, but because there's an inadequate amount of viscoelastic, the acrylic material kind of gets stuck on the plastic walls within the injection cartridge. So we have to find some more viscoelastic to more completely fill this cartridge. So I'll put it in a little viscoelastic below the implant and above or on top of the implant. And then I'll kind of grab the lens, pull it out, and then push it in. And because it has more viscoelastic, it goes down the chamber more easily. Now, as long as this lens implant is conforming to the bottom of the injection cartridge, that will lead to a successful delivery. If the optic is folded upward toward the top or the spine of the injection cartridge, the plunger may very well override or underride the optic and scuff the optic, which can adversely impact this patient's vision. We then use Kelman McPherson tying forceps, also known as smooth blue forceps, for counter intraction. We rotate the threads of the plunger and deliver this panoptix lens into the eye. And then I just use the metal plunger to position the lens into the capsular bag. Let's go over another case. So in this case, we can see the panoptix in its little cartwheel case. We rotate the top counterclockwise, and the lens is inside a circular fort or wall. That's the top wall, that's the bottom wall, and in between the top and bottom walls, there's a gap there and there. We can look at the gap kind of from the side profile. There's one gap. There's another gap. That's the gap where I place my smooth blue or Kelman McPherson tying forceps to grab the panoptix. There's an access point right there and another access point right there where it's easiest to pass the tips of the forceps to easily grab the panoptix lens. So again, I'm not grabbing in the area where the rings are. I'm only grabbing or holding the implant in the peripheral clear zone, which is not really used by the patient. So this injection cartridge is shaped like a little Dachshund. It's got short little legs, long body. The feet of the Dachshund are the bottom, and on the top has the bevel that's longer, the bottom has the bevel that's shorter, and on the top or the spine or the back of the cartridge you can see an outline of the lens implant. So the opening is somewhat oval in nature, and again the feet are on screen upper right and the spine is screen lower left. You place the lens in. Here we have a more generous amount of viscoelastic, so the lens will slide into the cartridge more easily. And you want to make sure the curve of the optic of the implant conforms to the bottom half of the injection cartridge right here. You do not want the optic to conform to the top half. So you want it to be folded like a potato chip, where the central area of the potato chip is closest to the bottom of the cartridge. So I'm actually going to pass my instrument above and push toward the bottom of the cartridge. And it creates a slight curve to the optic, which is actually quite important. Then I'm going to just push the optic into the cartridge. It doesn't really matter to me what we do with the leading or trailing haptics, as long as the optic is curved in the correct conformation. Again, curved so it follows the curve of the bottom of the cartridge, where the edges are toward the top and the center of the optic is toward the bottom of the cartridge. Then you take this Monarch 3 injection device. It has a little metal plunger, and that metal plunger is going to push the optic and the whole implant into the eye. We place the feet into the cartridge. There's the feet toward the bottom, and you advance it forward. You'll hear a little click. Right there's a little click, and that tells you the cartridge is well seated. And then you advance the plunger, and you watch to make sure that the plunger does not pass on top of or below the optic. If the plunger passes on top of or below the optic, it will scuff the optic, which can adversely affect the patient's vision. So here the plunger meets the back edge of the optic and advances the lens, but it's not overriding the optic. The optic is entirely in front of the plunger, and we can advance the implant downrange. When we place the panoptix into the eye, it doesn't matter to me personally what the haptics look like, because as the haptics emerge, I can pretty much figure out which orientation the lens is and which orientation the lens should be. So here the lens comes out where the leading haptic is in a S formation, which is not correct. We want it in a backwards S. So I rotate the injection cartridge, and as I rotate it, it allows the implant to unfold into the correct orientation where the haptics are in a backwards S conformation. So I know this video wasn't in perfect focus, but I hope it helps you understand some of the key aspects that we're looking for when loading and getting ready to insert a panoptix lens. Thank you and good luck.